everyone, welcome back to another video. In this video, we'll talk about the adrenal gland. First, we'll discuss what adrenal gland is. Then we'll talk about the two different layers of adrenal gland, which is our adrenal cortex and adrenal medulla. Then we'll go over the different hormone produced by the adrenal cortex, which is our glucocorticoids, mineralocorticoids, and gonadocorticoids. After that, we'll talk about the adrenal medulla, which produces the catecholamines, and we'll talk about the disease associated with those hormone production. Now, let's start with the adrenal gland. What do we need to know about the adrenal gland? Just a brief introduction. Adrenal gland is located at the top of each kidney, which we can see over here, and they have right and the left. On the right side, we see this as a triangular structure, whereas on the left side, it is semicircular or half moon side structure. That's what adrenal gland looks like. So two things: adrenal gland sits at the top of each kidney. Right side looks like triangular and left side looks like the moon or semi-lunars. Now, if you'll go deep dive and if you look at the layer, they are made up of two different layers. The outer layer, we call it adrenal cortex, and the inner layer, we call it adrenal medulla. Now, this adrenal cortex, the outer layer, produces three major hormones, and they are your glucocorticoids, mineralocorticoids, and gonadocorticoids. Glucocorticoids produces cortisol, mineralocorticoids produces aldosterone, and gonadocorticoids produces your sex hormone. About these three, one thing I'll know is this is associated with sugar, this is associated with salt, and this is associated with sex hormone. So remember your 3S. These are your sugar, salt, sex hormone. Now, let's just go in detail about each of these hormone production and the disease associated with that. The first one we have is our glucocorticoids, cortisol production. What can happen or what can go wrong? So, in the blood, we have cortisol. What will that do? The cortisol does two main things. It will increase the blood sugar and it stabilizes the mast cell to degranulate. So if it is stabilized, your mast cells are not degranulating. And as a result, mast cells are your immune cells. So as a result, your immunity decreases down. So what's the two things it does? Manages the blood sugar and stabilizes the mast cell. Stabilizing mast cells mean decreasing the immunity. Okay. That's what cortisol does. Now, there could be a condition where you can have hypercortisolism, meaning you can have too much production of the cortisol in the blood. Now, that could be associated with two different things. The hypercortisolism could be because of the Cushing disease, or it could be because of the Cushing syndrome, one of these two. Now, with the Cushing disease, what's the difference between Cushing disease versus syndrome? First thing we need to pay attention to is this word syndrome. When you see or hear the word syndrome, it basically means the combination of sign plus symptoms. So sign and symptoms is called syndrome. The difference between Cushing disease versus Cushing syndrome is the fact that Cushing disease is the excess level of cortisol, so is the Cushing syndrome. But the only difference is with the Cushing disease, you have the excess production regardless of the cause. It could be because of anything at all. It could be iatrogenic, which means that it could be a problem as the result of the medical treatment. You can give too much of the hydrocortisone or any of the steroid drugs causing us to have elevated level of the cortisol. Now, in the Cushing syndrome, it includes the excess anterior pituitary secretion of adrenocorticotropic hormone, which is your ACTH. What it does, it stimulates the adrenal cortex. So it stimulates the adrenal cortex to produce more and more and more cortisol. We just talked about this and we said adrenal cortex is the outer layer. Adrenal cortex produces three main hormones. One of them is your cortisol. If your anterior pituitary keeps telling the adrenal cortex to produce more and more, it will stimulate more release of cortisol. Now, regardless of how it happens, both of them will have the end result of having too much of cortisol in the blood. In this video, we'll talk about the Cushing syndrome because that's what we focus in the nursing school. You all have seen the signs and symptoms in your book, in your text, in your D12 or other places. With the signs and symptoms, you have C, U, S, H, I, and G. central obesity, collagen fiber weakness, urinary free cortisol, glucose, striation, hypercortisolism, iatrogenic, non-iatrogenic, glucose tolerance, and so on. But that's kind of a lot to memorize. So what I will say is pay attention to some of the signs and symptoms, which is really common, as well as it's tested more in the NCLEX. So we'll work on that. I have made this artificial image of this person here, and this depicts our Cushing syndrome. So moon face is the one I will remember. Pendulous abdomen is the other one I will remember. We will see the red striation, and the red striation could be seen on the belly in the places where we have too much of the fat. So like over here in these kind of regions, you'll see the red striation. You can also have the fat pad buffalo hump, which is usually in the back over here. You'll see the buffalo hump. Other symptoms include red cheek, thin skin, increased blood pressure, poor wound healing, thin arms and legs. So what happens is your arms and legs are thin, but you have the central obesity. So I will remember moon face, pendulous abdomen, or because of the central obesity, red striation, and fat pad buffalo hump. Okay, those are the signs and symptoms. Now, when we do the testing, what kind of test do we want to do? The test which we do includes urinary free cortisol for cortisol increase. We just want to see that if there is too much of the cortisol in the urine. If there is increased level of cortisol in the urine, it means that there is increased production of cortisol in the blood. You can also see the increased production of cortisol in your serum, saliva, and so on. The test, we also do something called dexamethasone suppression test, where we orally give the patient some dextrose. As a result, the body will not produce the cortisol if it is healthy, because the body already have a cortisol. But if a patient or a person have any kind of Cushing syndrome or disorder, then they'll produce more cortisol even though their body have the cortisol already present in them. Okay, that's the test we will do. Now, moving forward, we have treatment option. Treatment depends on what's the cause plus what's the severity of symptoms. If it is hyperadrenalism from the tumor, meaning that the adrenal gland itself have a tumor, as a result it's increasing in size and producing too much of its hormone, then we can do two things. We can try the radiation. If the radiation is not working, then we can approach for the surgical removal option. Other include, yes, surgical removal is also an option, but when we think of surgical removal, you have to be mindful that if you remove the adrenal gland itself, then the patient has to be on the hormonal therapy for the rest of their life. We need to replace the cortisol, we need to replace the aldosterone, we need to replace some of the catecholamines and those kind of things. So that's the hormonal therapy needed for the rest of life. That's all we have in the hypercortisolism or in the Cushing syndrome. Now we'll move for the other hormone in the adrenal medulla. Sorry, the other hormone in the adrenal cortex. Cortex means outside, cortex the outside layer. The other hormone is mineralocorticoids, which releases aldosterone. When you see the word aldosterone, two things I will have directly focused to is aldosterone retains sodium. Where salt goes, water follows. So if it retains sodium, it also retains water along with it. As a result, now your blood volume increases. If the blood volume is increased, it will increase the blood pressure as well. So aldosterone, too much, high blood volume, high blood pressure. Okay. Now let's talk about more in detail with the aldosterone. So when you think of the aldosterone, like I said, think of retaining sodium plus retaining the water. As a result, blood volume increases. As a result, blood pressure increases. There is two things that can happen with the alteration. You can have, with the alteration, we're talking both about the increasing the aldosterone level in the blood. You can have the primary alteration. Whenever we say the word primary, we're focusing on the gland itself. Okay, so for the most part, we have the primary aldosteronism because of the benign tumor of the adrenal gland itself. So you can have adrenal adenoma, which is just a benign tumor, or hyperplasia, increase in the number of cell production of adrenal gland. And now as a result, we have too much of the production of the adrenal hormones. The sign and symptoms for the primary hyperaldosteronism includes excessive fluid retention in the system, increased blood pressure. Why are we retaining this fluid in the body? Because we are retaining the sodium, and as a result of the sodium retention, we are retaining the fluid itself as well. It also increases your blood pressure, okay, because now you have more blood volume. Example for this primary hyperaldosteronism includes your Crohn's disease. Now, beside the primary, we can also have the secondary reasons. It includes things such as renal disease, heart failure, or cirrhosis of the liver. In this kind of situation, what happens is you have the retention of sodium because of other factor than the problem in gland itself. Okay, it includes renal disease, heart failure, and cirrhosis of the liver. All right. Again, for the nursing purpose, we'll talk about the primary hyperaldosteronism. Why we're retaining too much of the sodium in the primary? Because of the problem in the gland itself, mostly the benign tumor. And the one disease we'll talk about is the Crohn's disease. So we talked about this. I just created this artificial image where we're saying that we will have the consistent high blood pressure of 140. Sorry, that's not something. It should say 140, at least the systolic, and for the diastole, at least the 90. So what I'm trying to show you in this picture is we have the increase in the blood pressure, which makes sense because there's too much of the sodium, too much of the water retention, too much of the blood volume, too much of the blood pressure. You can see edema as the result of the fluid retention. And the other symptom, which is kind of like something which we need to be mindful of, is your low potassium. We know that sodium and potassium are antagonists in nature. If sodium increases, your potassium will decrease to maintain that gradient. So if you have too much of the sodium in the body, then you'll have low potassium as compared to the sodium. So those are the signs and symptoms. High blood pressure, too much aldosteronism, edema, low potassium, and many more. But those are the something which I want you to focus more on. What kind of test we can do? We can do the test for aldosterone level. We can see the plasma renin activation. How is that renin-angiotensin-aldosterone system, which gets activated as a result of the low blood pressure, is acting up? What are our electrolyte panels look like, such as sodium versus potassium? So the thing we need to do on the test wise is first, obviously, we'll check the aldosterone level. But we also have to make sure, like, why is that aldosterone level increasing? If you remember from your RAAS, renin-angiotensin-aldosterone syndrome, then you know that the RAAS syndrome work by retaining the sodium as a result of the aldosterone release. So it could be because of the too much of the aldosterone released by the kidney. And we'll also check for the electrolyte panels. These will give us an idea why the level of aldosterone is increasing, where is the cause in the body. Treatment, we can have a surgical removal, but first we'll try with the aldosterone inhibiting drugs. We always want to go from least invasive to most invasive. So let's try with the aldosterone inhibiting drugs. If it works. If not, surgical removal of the tumor is what we're gonna do. Okay. Now we'll talk about the gonadocorticoids, which is your sex hormone. The two hormones produced by the gonadocorticoids are androgen and estrogen. Things to remember: when you see the word androgen, that's your male hormone, and when you see the word estrogen, that's your female hormone produced by the female. What happens in this case is you can have a problem such as virilism, in which you can have too much production of androgen, high production of your male hormone, which is your androgen. In this case, this is how the image I have drawn, which is a basic idea. This is a girl with some facial hair. So a girl with a male like secondary sexual characteristic. Okay. So what causes it? Again, these are mostly caused congenital as a result of adrenal hyperplasia or adrenogen secreting tumor. So for most of these diseases, the problem lies in the adrenal gland itself as a result of tumor, as a result of cancer, and those kind of things. When we talk about the virilism in one simple word, It's the excess production of male hormone, which is our androgen. Sign and symptoms, you'll have ambiguous genitalia, which just means that you cannot determine whether if it is a male or female during the birth as a result of the increased androgen production, which results in like ambiguous genitalia in the newborn girl especially, and because the girls will have kind of like male-like characteristics. When we do the testing, we will check for testosterone level. If it is male, you will see elevated. If it is female, you're not supposed to see the elevation, but you will see the elevation in the virilism. We will also do the testing for other adrenal level increase, such as you'll check for your aldosterone, you'll also check for your cortisol. Maybe there is a problem in the adrenal gland itself. As a result, all these hormones are elevated. Okay. You'll also do the dexamethasone suppression test again to check for your cortisol level. We'll also try to do the imaging to rule out the tumor, if there is a tumor present. So now what's the treatment? We try with the oral corticosteroids for hyperplasia, which is the increased size of our adrenal gland, if the cause is hyperplasia of the tumor. If the cause is tumor, we can do the surgical removal of the tumor. Okay. In the process, if there is a need to replace the whole adrenal gland itself, then we have to go ahead and replace with the hormonal therapy for the rest of their life. And that's everything we had in the adrenal cortex. One more time, review. Adrenal glands sit at the top of each kidney. Right adrenal gland have triangular shape. Left adrenal gland is semicircular shape. Adrenal gland have two layers, adrenal cortex and adrenal medulla. Adrenal cortex releases three hormones, glucocorticoids, mineralocorticoids, gonadocorticoids, which in turn releases cortisol, aldosterone, sex hormone. In simple word to remember, when you say cortisol, it's the increase of sugar. When you say aldosterone, it's the increase of salt. Whoops. And I messed my screen. Just give me 1 second and I will cut that. Okay. So one more time. When you say cortisol, we say the increase in sugar. When we say aldosterone, that's the increase in salt. And when we say sex hormone, that's the increase in your sex hormones such as androgen. For this class purpose, we'll only talk about the androgen itself, okay? Now, I'm sorry about that. This is my first time using it, so I'm just having some trouble with it. Okay, now collectively, you can have problem where all three of them could be low. You can have low cortisol, low aldosterone, low sex hormone, and we call that condition Addison. So think of Addison as subtraction of all three major hormones, which we'll talk now. So mostly you'll see low cortisol and low aldosterone. When you think of that, think low sugar in the blood, low sodium. So when you think of low sugar and low sodium, with this part, low sodium, you can think with an idea that potassium might be elevated when we talk about the signs and symptoms. Again, could be because of two causes. You can have the primary or secondary. When we say primary adrenal insufficiency, anytime we use the word primary, the problem is in the gland itself. In this case, we have the adrenal gland, that's the culprit. And you can have the disease such as the Addison. We also call the Addison disease a poster child. It's totally an autoimmune condition, which is the result of the adrenal gland failure. Is it rare? Yes, extremely rare. I will say rare, not extremely rare, but it's rare. When we say secondary hypercortisolism, you have the deficiency of adrenocorticotropic hormone, which is caused by the disease in the pituitary gland. In secondary hypercortisolism, you have the low cortisol, but the only difference is that the problem is not in the gland itself, but rather problem is on the other part of the body other than the gland. Other cause includes the TV. You can have the TV that can migrate all the way to the adrenal gland. You can have genetic cause, surgical removal of adrenals could cause the low level of cortisol. Hemorrhage, AIDS, cancer are the other causes for have the low production of the cortisols, which in turn could be the result as Addison disease. Could be the result of the hypocortisolism. Addison is primarily for primary adrenal insufficiency. So, in simple term, primary problem in the adrenal gland, secondary problem other than the adrenal gland. In the primary, we have the Addison disease. So let's talk about the signs and symptoms. we just talked about this. We said all three of the hormone will be low. So you'll see the low cortisol. If you see low cortisol, you'll see low glucose in the body. You'll also see the hypercalcemia plus anemia. Those are associated with the low cortisol and are the signs and symptoms of Addison disease. The thing which I want you to pay attention to is there is a low cortisol, there is a low blood sugar, but there is a high adrenocorticotropic hormone because the body feels like there is low cortisol, which have to be taken care of, which sends the signal to the hypothalamus. Hypothalamus tells the anterior pituitary, and our anterior pituitary starts acting on it, so starts producing more ACTH. The other thing you'll see is the melanin stimulating hormone, and I want you to pay attention to that because that could be a really good question. Melanin stimulating hormone will be elevated, which is why the color of the skin changes, and that's why we call him poster child. Classic sign of Addison is your change in color. Okay. The other includes hypoaldosteronism. When we said that, we just means the low sodium. If there is low sodium, what will happen to the potassium? It will get elevated. If you'll become dehydrated, postural hypertension, weight loss, and those high renin plasma because of the low blood pressure. And those kind of things you can see. But the thing which I want you to pick up is low sodium, high potassium in this one. Lastly, you'll see low sex hormone, which could be result as loss of body plus pubic hairs, loss of libido or amenorrhea, muscle wasting, thin limb, and so on. These are associated with the low sex hormone. Okay, pay attention to loss of body plus pubic hairs. Now, those are some of the signs and symptoms associated with your Addison. When you want to do the test for that, how do you want to test it? There are several things we can do. We are not sure exactly which one is the problem. So we can do the ACTH, which will just do the stimulation test. If it is positive or negative, that can give us an idea that if the problem is in the pituitary gland with the ACTH level. In the Addison, you'll see the increase of ACTH level as a result of low cortisol production. You also want to check the serum cortisol level. What's the normal cortisol range in the blood and match it with the patient range. We'll check for the BUN and creatinine level. They will be elevated as well. We'll check for the electrolytes such as sodium, potassium, and then last but not the least, we'll also do the kidney testing to check for any possible adrenal TB, which could be the possibility as well. Treatment wise, first you need to find out what's the cause, and once you find out, then you need to, let's say if there is a low cortisol, give the patient cortisol. That's the best treatment. Give them cortisol, which is like given in the form of steroids. It includes oral cortisol, and with stress, you have to increase that. That's something you need to pay attention to because cortisol is called stress hormone. So if there is more stress, you need to have more cortisol to manage that stress. That's why you need to increase the dose with the stress. You can have the Addison crisis, which could be caused by the extreme stress, injury, infection. Stress does not just mean like, oh, stretching your body physically or mentally. Sometimes if you have injury or infection or surgery, those kind of things are really stressful to your body itself, which can trigger the Addison crisis. And sign includes the dysrhythmias. Why? Sodium goes down really deep, so potassium shoots up the sky. With high potassium, you can have the dysrhythmias. With low sodium, you can go to the hypovolemic shock due to the low blood pressure. Your blood sugar will go low to the point where you can go to the coma. So what's the treatment? We can give them the normal saline and treat it. Lastly, we can give them the IV hydrocortisone because IV hydrocortisone will increase the cortisol. Normal saline will maintain the sodium level in the blood. And that's everything we had in our adrenal medulla. Now we'll go ahead and talk about our other hormone associated with adrenal gland, and the layer is adrenal medulla. The adrenal medulla releases one hormone and one hormone only, but it's really fascinating. It secretes the catecholamines, which are your stress hormone. When I say catecholamines, the difference between cortisol and the stress hormone in this case is cortisol is a stress hormone that is released by the stress to the body, and catecholamines are released when you have stressful situations, such as you are running away from the bear and those kind of things. So it releases norepinephrine for the most part and small amount of epinephrine, which stimulates your fight or flight response. As a result, your body panics and starts doing. Your heart rate increases, your blood pressure increases, your temperature increases, your GI motility decreases, and those kind of things. The body is just trying to get away from the bear in that kind of scenario. So what happens is, eventually, if it is not treated, then death happens due to tachycardia. That's why I have this image over here that the patient is having tachycardia. So what's the cause of death in a patient with high amount of catecholamine production? We have your tachycardia, and we'll talk about one disease associated with that, and we call it Pheochromocytoma, which is derived from the word pheo means blue or purple, chromo means color, cytoma means cell, which just means the tumor of adrenal medulla, which is the inside layer. It secretes the catecholamines in the continuous episode. Sorry about this, I'm just trying to adjust the screen to the point where we can all see it. What's the sign and symptoms? Increase in cardiac output, your glucose release from the glycogen, ACTH, and thyroid stimulating hormone release, increase in mental alertness. All of this happens because your body is trying to be in the fight or flight response. Think I'll know is death, which is due to the tachycardia. Treatment option, you have to surgically remove the adrenal medulla itself, and once you're replacing it, that is a good possibility. You're causing damage to the adrenal cortex, which is your outer layer, and adrenal medulla. So you have to put the patient on the hormonal therapy for the rest of the life. And that's everything we have for the adrenal gland. Let's do the quick recap of everything we learned today. So we have adrenal gland at the top of the kidney take a step back, have two layers, adrenal cortex, adrenal medulla. Adrenal cortex releases glucocorticoids, mineralocorticoids, and gonadotropins. Cortisol disease is associated with that. We talked about Cushing syndrome, high sugar. Aldosterone disease associated with that. We have Crohn's disease, high sodium. Then sex hormone, we talked about the disease associated with sex hormone. We have virilism, which means high androgen. Okay, salt, sugar, sex hormone. If all three of them are low, we call it Addison disease. Addison means subtraction in this case. Subtraction of all three of the hormone. And then we talked about the adrenal medulla, which releases one hormone, that is catecholamines. And you can have something called pheochromocytoma, that is just the tumor of the adrenal medulla, which causes us to have high production of those catecholamines, which stimulates your fight or flight response. And as a result, we'll see the death because your heart is beating so fast. And that's everything we have for the adrenal gland. If you need this slide, let me know. Send a message. I will give it to you, or just write on the comment. Thank you so much for watching. We'll see you guys in another video.